Dr. Pepper, for inviting me. This is my first time here, and so I'm glad to be part of the course coming back in person. You know, we've all been yearning for that for the past few years, being boxed and limited to the digital world. Earlier on, we talked a lot about our facial nerves, and the reason why this is a part of my practice. It's not the only thing I do, but I'm excited about this because when I first joined faculty at Hopkins, I just saw how inadequate what was being offered. And it's amazing to see that over the past 18 years, so many more people have been trained and more people are interested. And there's a lot of basic science research, clinical and translational work supporting this field. So it's exciting to see where this is going to go in the next 10 years. If you do a PubMed search and you go from 2000 to 2022, you will see how steep rise the number of publications have been in a very short period. And it's just a reflection of we started with nothing and now we are really changing things. So whatever I'm going to talk to you about today is just something that is in transition, right? And because that's what makes reanimation of the face very exciting. There's a lot to learn and a lot of improvement to make. I'm going to skip this particular slide. Now, the animation of the face is very, very complex. As humans, we communicate verbally, we communicate non-verbally, and sometimes our non-verbal expressions say more than the words we say, right? So when you lose that, it's a big hit. Like you can imagine a grandmother being called by her grandchildren, why are you angry all the time? I mean, how do they recover from that, right? So our non-verbal communications and cues are extremely important. And that's where expression and animation of faces are very important. So when we think about it, in our field, we tend to do a lot with parotid surgery, and that's where we come in contact with the facial nerve. We almost never see the facial muscles. If you see the facial muscle, maybe in a dog bite injury, right? So when we think about paralysis, parotid facial nerve, and that's it. But this is something that is starting from the motor cortex and coming all the way down to tiny little fibers. There are no muscles in the body that replaces what the facial muscle does. They are very thin muscles, parallel pennation. A lot of them are not attached to bones like you see other muscles in the body work. They are not working a lot across joints. Even the way nerves innervate the facial muscles are totally different. So nothing replaces them. So muscles are key, facial muscles are key and delicately designed for what they're supposed to do. So you're going from the motor cortex with this complex network of nerves, and you're going to end up with an end organ, the kidney of the face, which is the facial muscles. I'm saying all these things because I'm going to put them together to let you see how we start thinking about the paralyzed face and how we can treat them. Okay, so this is a more detailed anatomy. As you can see, in a very small area, sheet-like muscles, very thin, but they can move a lot and they can talk a lot, and they can get you into trouble with what you say and when you don't say, right? And you see all these complex networks and that's what we are navigating through. So it's good to get a good sense of what these muscles are. But if you go back to neurology in med school, movement of the face starts from the motor cortex, but we have two systems. We have the pyramidal system, that is the voluntary facial movement, and we have the extrapyramidal system, goes through the limbic system, is the emotional portion. We always think about nerve and muscle, but you have to have this big global picture in your mind that there are two systems working and both are very important, right? But it's common denominator, regardless of where they go, they end up in the facial muscles. And just keep this picture in mind because we're going to use it to determine what to do when you're presented with a patient. So this is a patient who the pyramidal system is affected, but her face is also showing no expression at all. She's an acoustic neuroma patient. Facial nerve was totally cut, right? I can't play this video, But when I asked her, what would you want me to do again? She said, I just want to feel good about myself again, right? She didn't talk about paralyzed. I just want to feel good about myself again. So these are the two systems that we are working with. This is telling you how the two systems, pyramidal and extrapyramidal, can be dissociated. This patient has paralysis and is from a stroke. When you ask her to smile, she can't move it, but when you crack a joke, she can smile. So that tells you that, yes, we are looking at two different systems, and the pathway across which it goes makes a difference. So I was presented with a patient young patient, 38-year-old, young kids, car accident, stroke, in the area that kind of dissociated her pyramidal system from extrapyramidal system. And then she was presented to me with somebody with bilateral facial paralysis. And I'm looking at her, she has nicely formed nasolabial folds, commissure intact. I can tell her face moves, but she thinks her face is paralyzed. It's because she was almost like locked in. She could not access her extrapyramidal system. So when her kids come into the room and she wants to show emotion, she couldn't. But she could move her face. She could move her face, right? But she could not access emotion to trigger the face. So she said, fix it. So what did I do for her? I gave her a new trigger. I said, okay, I'm going to connect a masseter nerve to your facial nerve, not because your face is paralyzed, but I'm giving you a different trigger that whenever your kids come into this, you can clench and show them some emotion, right? This is the reason why you have to understand the whole system. Otherwise, you will be presented with this patient and say, your face is not paralyzed, your face moves. So what do I do? You got to understand the system so you know at which level you are trying to intervene. So we are dealing with a very complex system, to the extent that when you give people Botox, I said it earlier on, you actually affect things more proximal than the facial nucleus, and you can tell on functional MRI. This is the reason why in most of the things that we do, it's not just connecting nerves. Sometimes you have to include a facial retraining specialist, because they work at the levels that our Botox can work. They work on the brain, right? They get people psychologically prepared to deal with what they have and to adjust to what they have, so they can really draw on the strength of their brain, because at the motor cortex, at the limbic cortex, Botox doesn't work directly, but it works indirectly. So this is the entire system we're dealing with when we talk about facial reanimation, more than just muscle and nerves. Okay. Now, when somebody's face is paralyzed, we say the face is asymmetric, and then we want to fix the asymmetry. But asymmetry is normal, it's natural, it's biologic. There's asymmetry in a lot of the things that we do, but the degree of asymmetry is what kind of brings our problem. And the most exaggerated portion of asymmetry is a completely paralyzed face. So there are grades, right? We know that because this is a structure of thalidomide, right? There's the L isomer and the D isomer. The L isomide is the one that is a teratogen. The D isomer has no effect on the embryos, right? But it's a sedative, right? This is asymmetry. Mona Lisa is here, asymmetric face, but this painting costs a lot. So asymmetry is normal in our world. It should be accepted. Some degree of asymmetry is okay, but exaggerated asymmetry with paralysis is what we're dealing with. How much asymmetry is acceptable when we're looking at someone's face? This is one of our former fellows many, many years back. Pictures that have been morphed, right? If you look at the picture right now and just take a quick glance, there's nothing wrong. Till you get to the last picture, there is about 3 millimeters of asymmetry between the oral commissures on both sides. If I just kind of had you look at this picture for just 2-3 seconds, you won't see a difference, right? Asymmetry beyond some point starts becoming more obvious to patients, right? So in the things that we do, sometimes I'll say, yeah, your commissures are asymmetric, but it's 3 millimeters or less, so we don't have to do anything. How about the eye? Somebody has synkinesis, and the only thing that bothers them is the eye. How much of asymmetry in the eye would attract attention? So we are dealing with asymmetry. Asymmetry is not natural, but what degree? So that's how we analyze faces, so you do something about it. I'm going to skip this. We talked earlier on about the measures that we use to assess the face. To me, this is my grading scale for an animated face. This is my grading scale. If I can't get this, my techniques are not good enough, right? So this is an animated face. What do you see here? The eyes are squinting, they are small. You can see cheeks mound, they reflect light. Nasolabial folds are deep. They're telling me some muscles are contracting. I can see labial elevation symmetrically on both sides. I can see full dental display, 4 out of 4 on the right, 4 on the left. Interlabial gap symmetric, lower lip showing gum, right? This is an animated face. So when we say facial animation, if our grading skills don't get us to this, we need to adjust our grading skill. You understand? So if your grading skill that didn't tell you what the eye is doing and what techniques you can use to solve it, what the cheek mounts are doing and what techniques you can use to solve it, how you can communicate that to patients, to me, that's a complicated grading skill. That doesn't help me. It doesn't help me decide what to do for a patient. It just makes me feel good as to where the state of the art is right now. But this is the gold standard, is the creatinine level of the face, right? This is it. So this is what I have in my mind to tell me my techniques are not adequate, so I can't be so happy about it. So we need to push the envelope, right? The emotions that the face make, the smile is the one that has the biggest penalty if you lose it. Why? Because you smile, the other person who sees it smiles back, and it does something to oxytocin levels in our brain, right? That's why when you lose the ability to smile, the penalty that we get from the socially is very high. So is this person smiling? Are all smiles the same? Do all smiles have the same value? We always talk about patient has a Mona Lisa smile, but the Mona Lisa smile is only expensive in France, right? But the Mona Lisa smile, as of now, for a reanimation surgeon, is the baseline result we should ever be looking for. We can improve you and give you a Mona Lisa smile, but we have to kind of go beyond the Mona Lisa smile. I think the Mona Lisa had Bell's palsy. And which side do you think he got the Bell's palsy on? Right or left? Right? I think maybe it's left. You see, the left commissure is elevated compared to the right. So maybe he was synkinetic. Maybe he had Botox too much. How about that? Okay, so not all smiles are the same. We are moving on to animated face, so we have to know the different kinds of smiles and the emotion that kind of is associated with it, so that as we push our techniques, we say, okay, this is what we want. We're not there yet, but this is what we want. So this is inadequate, we need to change. There's the enjoyment smile, which is the Duchenne smile. This is the gold standard. If you do, it's the same smile that I showed you on the other patient. Squinting eye, deep nasolabial fold, elevated cheek mounts, gums showing, if you have a gummy smile, right? No labial drip, we can see teeth, right? That's the smile that we want. The social smile is the middle one. The social smile, every single one who's been stopped by a cop has had one, you know? You were speeding, really? Because you smile, you don't want to get a ticket. Right? That's the social smile. The social smile is the one someone says hi, you say hi back, but you don't remember their name, but you have to be nice, right? That's the social smile. And then the last one is the Mona Lisa smile. You just kind of pull the corners of the mouth. We want the enjoyment smile because that has a high emotional positivity attached to it. Our techniques should get us there. And if it's not getting us there, we have to assess what we are doing and say, this is what we need to do to get there. Okay, and as we're doing this, we should pat ourselves on the back, but we should understand that the patients that we are taking care of do not interact only in clinical spaces. They are in society. So they pay social penalties for it. So the grading skills that we use and how we communicate to them has to be in a social setting. What do their friends say? What would the grandchildren say? Are they paying penalties for how their faces look? Are we bridging that gap? So there's something that at Hopkins we've done a lot of work with, and it's called the eye scan paths. Naturally, when you meet anyone, your eye takes a quick scan of their face. You go to their eyes, the tip of the nose, you go to the lip, and you come back to the eye. That's the natural scan path for almost everybody, unless something starts getting wrong. Maybe the commissures are more than 3 millimeters apart, 5 millimeters, or there's a scar, or there's a cleft lip, or there is a paralysis. Then you start seeing it. The scan path starts changing. When you use a scan path, you can say, okay, this scan path is warm and is focusing on the paralyzed lip. And when we do your surgery, we've actually corrected your scan path. So when your patient tells you, everybody stares at me because my face doesn't look good, I can tell them, your scan path says, nobody is seeing your face, they see your eyes, right? So it's one way for the lay person to be able to assess what we are doing, to say that when they go into society, perhaps they are doing okay. So we use different tools to try to assess paralysis and assess and evaluate the things that we are doing. There are different reasons why someone will come and see you for paralysis. The most common by far is Bell's palsy. So earlier on, there was a question, in our field, we should determine the areas that we really want to move the needle. It's not gracilis, it's not nerve grafts. If it's anything, I would say it's the Bell's palsy. It's the majority of patients we see. And if we really want to make a difference, that's the area we should make a difference. But for my practice, I see almost every single type of patient. The ones that are strange are patients with actually facial dystrophy. There's a disease entity called FSH. They will have a scapular winging. They will have progressive dystrophy of the facial muscles. Most of them will have had fixation of the scapula, but there was nothing being done for the face. So you have to be able to go through your mind. There's nothing wrong with the nerve, but this face is progressively weak. And also understand that not only is the facial muscles weak, other muscles may be weak. So determining what you do to reanimate the face, you have to think about the disease entity. And of course, there are the congenital causes and trauma and parotids. But by far, you're going to see more Bell's palsy patients, so you have to be ready to take care of them. Beyond the causes, there are some functional issues that we are always trying to take care of. The pressing issue being corneal protection, but the last one on the list is not the least, the psychosocial impact that we also always have to think about. Okay, elderly patients tend to actually suffer more from it. There's a study that we did to show that the techniques that we would do for young people, actually elderly people do benefit even better from it because they don't have the reserve to compensate for the paralysis that happens on their face compared to others. They won't eat in public because they drool and they can't compensate for it. They don't have the ability to just use the other side of their cheeks to push food around their mouth like a younger person do. So when you're picking techniques, you don't use an age to say, this is an older patient, you can't do this for them, let me do something simple. They may be the group of patients who actually benefit more from the techniques that we have. But depression, eye problems, drooling, social isolation, oral face dysphagia, and speech issues. So those are the functional issues that we are usually working back. Okay, so this is the yardstick. We have to find metrics to be able to measure this, right? And judge our techniques based on that. So there's a study that one of our former fellows did, looked at all the grading scales that are there, lots of them. The conclusion is there's so many instruments, different ones being used in publications. None of them actually is used consistently. So we need something simple that is relevant that will allow us to be able to communicate to patients directly, like I mentioned earlier on. So I use simple stuff. I'm not saying you should adapt this, but I use simple stuff. For tone, for facial tone, I'm usually judging the commissure position to determine tone. I just said that if your symmetry in your commissure is less than 3 millimeters, usually you're fine. I'm using that to judge tone of the oral commissure. So I just measure from the medial canthus to the oral commissure on both sides, subtract the number. If it's 0, you are perfectly symmetric, regardless of what you tell me. Don't use this. I'm just not adding another grading skill, but it's a simple thing that I use. If you are 3 millimeters, I would say your asymmetric index is 3. If it's 5, it's 5. Then at the end, I want to see, did I bridge the gap? Okay. But this is the thing that I communicate with patients with. right? This is simple. They see it. I didn't make this up. I adapted it from the dental literature. If you smile, I'm looking for what we call the anatomy of the smile. The lips are the frame of the picture. The teeth is the picture in the frame. I want to see how many teeth on the right side versus the left, and I call that dental display, right? And then usually I'll write dental display 2/4 right over L to show the right side is the 2, the left is the 4. So always I know what I started from. It's not always so clear that they only showed one tooth, maybe 1.5, right? You can see one. That way, when I come back, I can tell what did my procedure give me more exposure of the smile display area. So the easy thing is for us to do the Mona Lisa smile and measure the excursion of the curvature. But earlier on, I said, nobody walks around and says, my smile is 1 centimeter, right? They don't do that. They want a smile, and for the smile, it's a framed lip with displayed teeth. That's what they want. And then we want to see the cheeks mounted up, and we want to see the eye squinting. That is it. So this is how I communicate with patients. I just show it to them. When you smile, I can see this kind of laying over your lip. So the technique that we want to elevate the lip to expose more teeth. In some people, you think their smiles are crooked, and you're going to go do a gracilis, but the problem is the lower lip. The lower lip is masking the dentition. So you do a gracilis, you may get some more movement, but you really didn't do anything for them because the lower lip is still hanging over the lips, right? So if I know that I'm doing a dental display and I use my finger to pull the lower lip down and I take a picture and I show them, see, your smile is actually really good. Your problem is just the lower lip. Unfortunately, we don't have anything really good for the lower lip now. Okay, so maybe we push our goals and change it to make it more symmetric. Then I go through, there are 3 different types of smile. Some people smile and you see the upper teeth. Some people smile, you see the lower teeth. Some people smile, you don't see anything. So we're going to switch your smile from this type to that type. It makes more sense to them when they know that we don't have the technique to pull the lower lip down adequately, right? We are working on it, but we don't, right? So you don't go and do a gracilis because they read about it, because you won't get too much out of it. So this is the way I just communicate with patients. So this is an example, 6 out of 6, 2 out of 0. So summarize, animation is complex. We need simple, objective measures to challenge what we do. Okay. So you are presented with a patient. So what do? You know all these metrics, you know the limbic system and all these pathways. What do you do with the patient, right? I work my way back from the muscle. You remember that algorithm? The muscle is the end organ. So I want to know what the muscle is doing. Then I can work my way backwards to determine what to do. Okay. So from the muscle standpoint, is the paralysis partial? Or is it a partial paralysis, incomplete paralysis, or is it a partial recovery? That is the top of the list. Then on the bottom, it's a complete paralysis, but it's irreversible. Oh, irreversible in this scale, reversible. Complete paralysis is reversible. Someone had parotid surgery, the nerve was cut. The surgery happened last week. Before they went to surgery, they could move and smile. That is a reversible muscle, right? It's a complete paralysis. It's a complete reversible paralysis. I need to get a nerve into that muscle as quickly as possible. Simple for me, right? In the middle, irreversible complete paralysis. This patient was born with the Mobius syndrome. Doesn't have any muscle, doesn't move, irreversible. There's no muscle to reverse. My decision is made. This person had surgery 2 years ago. The nerve was not cut. They expected it to come back. It hasn't. There's no tone, nothing, right? 2 years, we can debate, but to me, irreversible paralysis. This patient had surgery 6 months ago, received high-dose radiation. Face is stiff. It's 6 months, irreversible. That muscle, I cannot change it to become dynamic. So when I have this frame in my mind, I can put patients into categories. Then it helps me decide which pathway to take. So this is just a rough. I'm going to add another layer to this simplified way of splitting patients to see an additional thing that I say, all based on the end organ, the muscle, to decide what to do. Okay. And that's the dynamic potential of a muscle. So muscles have a dynamic range. Your facial muscles have a basal tone that holds your face up. And when you want to smile or move it, there is recruitment, an upgrade in impulse, then you contract it more, right? But at rest, it's just not doing anything. There are action potentials going into it, giving you a basal tone. Okay, so on this spectrum, if you lose innervation, you go all the way to one side, which is flaccid, but you can go to the other extreme and become spastic. But the dynamic range is somewhere in the middle, from the resting tone to active excursion. That's where you can get recruitment. When you go spastic, you cannot recruit a spastic nerve. The myosin actin, 100% interacting, non-contractile muscles, elements frozen up, you can't recruit that muscle. So if you tell me, go and innervate that muscle so you can get more movement, you're not getting any more movement, right? But on the other hand, flaccid, irreversible because it's too long, the muscle is gone, so there's no muscle to recruit. You need a new muscle. Flaccid, but reversible. It happened 4 months ago, 3 months ago. There is a muscle to recover, to recruit, so innervated. So beyond keeping myself complete, incomplete, I want to know what is the dynamic potential of that muscle? And then I make my next level of decision. And I use this spring to sort of illustrate the same point. The dynamic range is the portion that the spring can go back and forth. Flaccid is when you really pulled it out, right? And the spastic is the spring is so contracted, there is no more room to go. So I asked my question, is this a reversible muscle? What is the dynamic potential of that muscle? Why? Because somebody may come to you and you think, they say, I just want more symmetry, right? They are 18 months out. If I innovate it, I may get a little bit more tone. They respond, but the dynamic potential is not that great. So if that person tells you, I want a normal smile, I can't give it to you at 18 months. If I innovate it, you can get some more tone. I don't think you'll be smiling like you used to, right? So I use that to give myself another level of decision-making to decide what to do. So we'll look at some examples. So facial nerve person, let me see if this works. Yeah. Muscle present, yes. Physiologically viable, yes. Based on duration of paralysis. What's the dynamic potential? Poor, you need a new muscle. Average, let's discuss what your desired result is. Good, innovate that muscle. So that's the way I categorize it. Okay. We've used this as an illustration already. So if there is a good dynamic potential, if the dynamic potential is poor, you need a muscle upgrade. If the dynamic potential is good, you just need a signal upgrade. Signal means put more nerve, that muscle upgrade, put a new muscle. Okay, this is a patient with Bell's palsy. He comes in like that. Oh, sorry. Okay, I've gone through, does this patient have a dynamic, a physiological viable muscle? Answer is yes. What is the dynamic potential? She is somewhere overcontracted in this area, right? And if this has been there for like 15 years, non-contractile elements are frozen, I would say the dynamic potential of these muscles are poor, right? If I decide I'm going to innervate this muscle to get more movement, I won't get any more recruitment. So that's the way I would think about this patient. Okay, this is a patient with bilateral Lyme's disease. Let's see if the video plays. Okay, are the physiologically viable muscles? Yes. What's the dynamic potential? Early on, I did her case maybe 16 years ago. I said, oh, these muscles are there, they just don't move very well. Dynamic potential, average. Maybe I can signal upgrade and get it a better movement. So that's what I did. Dynamic potential, average. I did bilateral masseter nerve transfer. This is the result I got. Is this better? No. But she was happy because she felt she had control over her face, right? My thought process at that time, not good. I thought, oh, dynamic is a viable muscle. If I did EMG, it would tell me muscles are viable. So maybe I should innovate it. Wrong decision. She saw patients that had done gracilis online, and then she called me and said, oh, there's something new. Your results are better. Am I a candidate for it? I said, I will have to undo everything that you've done. And that's what I did. I just went in and did a gracilis and recycled her masseter nerve, and then she got better result. Okay, so what I know now, I would not have done what I did at that time. This is a Bell's palsy patient, so let's use the same criteria. Asymmetric dental display, oral commissure is down, the lateral gutters are effaced on the side. Dental display, how would I grade it? 1, 2, 3 over 5. That's what I will grade it. What's the physiological viable muscles? Yes. Dynamic potential average, right? It's a synkinetic muscle, spastic muscle. What is my solution? This is a Bell's palsy. If I innovated signal upgrade, I don't think I will get a better movement. I don't need a new muscle. Can I optimize the movement of this muscle? That's what we did. So that's the way I go through the algorithm. This is a patient who had vestibular schwannoma. Facial nerve was cut. Does she have physiologically viable muscles? Yes. Was the potential? Excellent. It just happened. So I need a nerve to get into that muscle as soon as possible. And in this case, muscle time is muscle. I mean, just thinking about it, I think if I innovate you 1 month now versus 4 months now, I expect you to do better 1 month than 4 months. Why? I don't have a lot of data to say otherwise, but why would I wait for the 3 months of your nerve muscle to deteriorate? And in addition, when you do the innovation, it's going to take average 3.5 months. So that is paralysis for 3 months, additional 3.5 months before the nerve gets into the muscle, plus growing into the muscle. So that's almost 9 months. For me, there's no reason to wait. So you want to do it as fast as possible. So that's the way you use the end organ to decide what you're going to do. Okay. So now we have a framework to see and evaluate patients. Now let's come down to the things that worry patients. The first thing that we always learn about is all about the eye. Okay. And we have a sense that you have to help patients close their eye. But I don't think closing your eye should be the goal. We had the oculoplastics surgeon talking about blink. To me, I put more premium on blink than closing your eyes. Because you can have someone close their eyes the whole day. Number one, it's not normal to have your eyes closed during the day. Number two, if you close your eyes, those meibomian glands that you was talking about, the glands and the oil and the tears will just be sitting in one place and it's not doing anything, right? So I don't put the premium on, I'm going to help you close your eye. I have to have this discussion with the patient. I put a premium on, I'm trying to improve blink efficiency. That's my goal. Now, the most common procedures we learn about helping eye is the upper eyelid loading. Okay, blinking is a very finely coordinated movement between levator and orbicularis. One relaxes, the other one contracts, the other contracts, the other one relaxes. The weight, the loading is doing the work of the orbicularis by passively pulling the eyelid down, then the levator will pull it up, right? If you start putting heavier weights on the eyelid, it gets to a point the levator fatigues. It can't pull it back up, right? Your eye will be closed with it because you have a heavier weight, but the levator is fatigued, it can't pull it back up. So you have a sluggish upward movement of the eyelid, and it's not very effective like a windshield wiper, right? So I don't tend to put heavy weights with the goal that I saw your eye closed. I am interested in how effective it's going to make the eyelid go up and down. So how do we do it? This is infrared camera that we use to track eyelids. So in fact, in patients, I used to put eyelid weights and then we'll use the infrared camera, just getting data, kind of see the excursion, and we will change the weights and position till the blink efficiency is maximal. And there's a way for us to be able to tell. And when we map things up, you will see as you increase the weight, blink efficiency goes and then plateaus, and beyond some weight, it actually is counterproductive, right? So the weights are not being put in to close the eye. The weights should be put in to help with the blink. And in addition, don't make them look weird, like they have a droopy eyelid all the time. Okay, so this is the fine area that you're looking for. So in this infrared, we can actually look and trace excursion, and then I can tell the percentage coverage of the cornea with each blink, and then pick, this is the weight you need. Now, I did this for a lot of patients, and I sort of figured out the weights that I should use. I never go beyond 1.2. Most of the time it's 0.8 or 1.0. Those are the two ways. If I have to go way beyond that, I have to start thinking of something else. So smaller weights determine the ideal location, more with the goal of effective blink, and then they do blink exercises. Okay, not everybody is a good candidate for eyelid weights. So this is a negative vector eye, and we've seen examples of it this morning. You put the weight on, it sits on the North Pole, and it's not going to come around to the equator. It's just not going to do it, right? Eskimos, they just want to stay up there, right? So I have seen patients who have had multiple eyelid procedures. They put the weight in, it doesn't work. They put the heavier weight in, it doesn't work. They take it out, then you pull out the lower eyelid, multiple procedures, and then it ends up with, we're going to cut your levator and make it, put a spacer and then push the eyelid down just so you can cut, you've lost the plot, right? And it's all because you're trying to get something that would not work with someone with a negative vector eye. So when we have a negative vector eye, it's a different issue altogether. We have to think about it in a different way. Now, we so happen to be otolaryngologists, and we've taken a lot of trauma call. If you've been on trauma and somebody gets a baseball whacked on their cheek and they blow out their orbit, they get orbital decompression and their eye sinks in, right? And how did the baseball do it? It broke the floor of the orbit and the eye just went back. So why can't we, in a controlled fashion, baseball the lower eyelid or the orbital floor and let the eye sink back in? So in cases where I am presented with patients with a negative vector eye, or they've had multiple procedures that are not working, I'm going to decompress the eye and give the globe a more favorable relationship with the eyelid, so it doesn't have to work so hard. And there are different ways of doing this. If the patient has had multiple lower eyelid procedures and I'm very worried, I will go transmaxillary, small incision, a bone window, put a camera in. It's a beautiful view. If you put an endoscope in the maxillary sinus, you can actually see mucociliary action, controlled fashion, moving cilia and mucus towards the ostium. You don't want to disturb it. You just kind of maneuver your way through. And all you have to do is find the inferior orbital nerve, go medial or lateral, take a bone window and cut into the period and let some fat push down. Just like trauma it happens in trauma cases. This time, we're not going to fix the floor fracture. We are creating the floor fracture. And then you see the eye sinks back. And now you can use a weight if you want to. Sometimes you don't even have to use a weight. You can find out that the patient's eye actually closes much better just because you decompress them. Now, if you do that, you're going to do it bilaterally for symmetry. This is a little bit different from orbital decompression for thyroid disease. For thyroid disease, it's more aggressive. This one, you just need just a little bit to set the eye back. Okay, and that's what you get. Now, for negative vector eye patients, if I don't do decompression, I'm beginning to do more and more of palpebral springs. I think the palpebral springs are beautiful. I think we've just not learned, the technique has not been passed over because it had a lot of problems, a lot. Extrusion, and it's technically difficult. So we're trying to figure out how to put some science behind it and make it more consistent. So you hear a little bit more about it, trying to be more very thoughtful about how to use eyelid weights. You can put a weight, you can put a spring. If the person doesn't have sensation in the cornea, nothing's going to happen. They're going to have problems. So in cases like that, you need to do something else. I had a patient recently who I did a gracilis for paralysis, facial schwannoma. He looked great. And then he went to see his cornea specialist with redness in the eye. And the cornea specialist told him, go back to your surgeon and let him push your lower eyelid higher because your eye is now irritated. And I'm looking at him, I said, close your eye for me. And he closes very well, but his eyes are injected. And I'm wondering what happened. He had a residual acoustic neuroma. So they went back and did another surgery. It didn't affect my gracilis. It was fine. It didn't affect the eyelid closure, right? But now when they went back, they now denervated the cornea from the revision surgery. So even though he has good eye closure, the cornea still wasn't healthy. Okay, so I had to tell the cornea specialist that the patient's cornea is not sensate, and that went down very, very nicely. and so in cases like that, what do? Fortunately, you can neurotize the cornea. So you pick a sensory nerve, either supraorbital, infraorbital. If it's ipsilateral, it's actually an easier procedure. If this ipsilateral sensation in the infraorbital, you can go through the conjunctiva to the floor of the orbit, find the infraorbital nerve, release the fascicles, and your ophthalmologist will help you kind of track them around the limbus. If there are no sensory nerves on the ipsilateral side, then you have to graft from the contralateral side. So in this patient, you're seeing we grafted from this side, and the nerves are going to come to the other side. This is the time that I really like the great auricular nerve, because as the great auricular nerve gets towards the ear, the fascicles are already teased out nicely for you. And so when you use that as a graft, it's easier to use. So you can see that we kind of free them up, and then they would carefully dissect and then kind of track them around the limbus. If you see them cut around the limbus and kind of hydro dissect, I said, they do crazy stuff. We don't, yeah. Yeah, let's skip this. So it's just, I won't do this by myself. I would do all the nerve grafts and just feed the fascicles to them and let them finish it up. Okay. This is the neurography done on that side. These are not my patients, but you see that not only do they have sensitivity, the cornea health actually improves. This is another patient, and there's a very elaborate way to assess for your outcomes. So we have static ways, loading of the eyelid, springs, decompression, but really long-term eyelid, the best way is a dynamic reanimation. Right? That's the best thing. That's why people with static procedure in the lower eyelid, after 5-6 years, they need to have something done. So if we can reconstitute the muscles around the eye, it will be ideal. So we should know that we are not there yet, but we should look for options to be able to do that. And we are. So one of my trilogic thesis was on using the omohyoid muscle as a source of muscle to reanimate the face. And one of the reasons why I thought about it is that the omohyoid muscle looks like the orbicularis oculi muscle. So this is not orbicularis oculi, this is actually omohyoid muscle. So there was a time, any neck dissection that was done, I did the dissection around the omohyoid. As soon as the head and neck surgeons get there, they stop. I come in, I tease it out, so I could learn the innervation, the vascularity, just so we can use it as a flap. And we've done clinical cases. The muscle is ideal. The pennation is parallel, similar to a zygomaticus major muscle. We actually did muscle excursion studies to show the force of contraction, and it's very comparable to the zygomaticus major muscle. And the pedicle can reach the superficial temporal. The nerve can reach the contralateral side. So it's an ideal muscle looking for something to do. So that will be a good addition to the things that we do. This is a platysma flap that we've elevated. The vessel here is superior thyroid, and this is the nerve to the platysma. Now, putting this muscle around the eyelid, do not expect it's going to blink like a normal eyelid. This is just a start. If I can get tone to the lower eyelid and keep the lower eyelid up, that's half the way, right? Versus nothing, versus using slings, versus using sutures. So there are things that we have to be thinking about. This video, it won't play, but I wanted to show an example of a palpebral spring. This is a patient who had a weight, and they put the heavier weight and the heavier weight, and she still couldn't really have good eye comfort, and I switched it to a spring, and right in the recovery area, she said, it just feels great. And you can see the blinking of the eye in concert with the contralateral side. So palpebral spring is something that we should be thinking about, and I have ways that I'm trying to modify that procedure and use force excursion curves to try to make it more predictable. So stay tuned for that. Let's see. This is platysma flap. So these platysma flaps have been done for the eyelid and neurotized. And this is actually a patient that not my patient, a published patient. And you can see when they stimulate it, you can see the contraction on the eyelid, and this is all platysma muscle. So imagine if you have the muscle and you can innervate it with a contralateral orbicularis branch, then we have something. This is done in two ways. Platysma muscle is thin enough that you can just put it in as a free graft, and it will become vascularized. And then as a second, the way you do it is you would do a graft from the contralateral side and let the nerve grow till it gets to the eyelid on the paralyzed side. And then as a second stage procedure, you take a free platysma muscle, then lay it around the eye, and then let it either directly neurotize the muscle, or if you can find the nerve like I did, hook it up. Alternatively, you can harvest it with a vessel and then try to vascularize it. Okay, so that's that for the eye. If there's one thing that I think is critical for outcomes in the reanimation is how the duration of the paralysis. And in general, I tell people the sooner the better, the sooner the better. Why? The ideal situation is a case that you are expecting recovery, but you just don't know how long it's going to take, right? If you have someone who's an acoustic neuroma patient, tumor was removed, nerve was intact, they wake up, their faces can move, and you have to reassure the patient your face is going to recover. Do you tell them you're going to wait for 3 months, 6 months, 9 months, 12 months, 18 months? What's the time? Okay. To me, the sooner the better. And the timeline I use is 6 months, and it's based on data. And even the 6 months, I find anything I can do to push that timeline to an earlier date. If I can do it 3 months than 6 months, I'll prefer to do that. So I speak to the neurosurgeon and a neurologist, and they would tell me, you know, that nerve fascicles were really splayed and we really had to work very. Those are all code words that the nerve is not coming back, although it's anatomically intact. So I find any of those reasons to do it sooner. In addition, if I go in sooner, I'm not going to cut the main facial nerve. I'm going to keep it in continuity. I'm taking a branch. I'm not burning any bridges. So if I hook a masseter to a buccal branch, if that facial nerve is going to recover, it still has a pathway to come through. The only thing I've sacrificed is that buccal branch that I cut, and so that in case nerves are coming out, they may escape through that branch. If you don't want that to happen, you can do something about it. You can clip right at the takeoff, so you force the axons to go the right way. You can reroute that proximal cut end back to an adjacent branch. So to me, there is no reason to wait too long, right? There's no reason. You don't burn any bridges, because the alternative is that you get a muscle that you innervate and you don't get an optimal result, and now you're going to be having to do more stuff, right? So I don't wait on them. Okay, I'm going to skip this. We've seen this already. So this is the study that I first did to tell me wait 6 months, don't wait beyond 6 months. It was presented earlier on. That was more of a retrospective study, but we also did a prospective study to confirm our initial findings that those who waited 6 months and didn't have any clinical evidence of recovery went on to have no appreciable recovery that did not require intervention. So 6 months, if I don't see anything moving your face, I want to do something. And if I'm going to do, I'm not going to cut the main facial branch, I will take one branch and leave the rest to see what happens. Okay, so that's one take-home message I would like to really push on. So I tend to group my patients 0 to 6 months early, 6 to 12 months intermediate, 12 to 18 months delayed. At this time, I'm telling you, okay, we can do it. We may get improved, may not get good movement. If we get good movement, great. Understand that if your goals are more than that, you may need additional surgery. You just tell them upfront, and so they don't come back and tell you it didn't work. Okay, greater than 18 months to me, it's late if I want a good smile. Okay. The most common group of patients you're going to see will be this group of patients. And I said, to me, the term synkinesis is just one portion. There is this spasticity, there's this twitching of the face, and if I group them all together, I would say it's an aberrant facial nerve syndrome. right? Then I can start thinking of the various categories and an understanding of what to do. The pathophysiology is base-directed nerve axons, incomplete myelination. Myelination is important for nodes of Ranvier, so action potentials can skip, right? When the nerves are injured, they become demyelinated. When they recover, the myelin sheath doesn't come completely. As a result, sodium channels are abnormal, right? Some of the causes of this is actually viral, neurotropic viral-induced injury to voltage-gated channels. So there is something going on with how sodium moves in and out. And there are actually RNA-based mechanisms for why this happens. So it's not just misdirected nerves. How action potential generates is also altered. And so that can be a target for the things that we do. And you're going to hear more about this tomorrow, so I'm not going to go into it in details. The common patterns, oroplatysmal, orocular, ororal, it tells you just because of the density of nerve branches. So if a nerve is going to stray its way to one way versus the other, the probability of going to the eye and mouth is greater. That's why we see that. So those are the misdirected nerves, but it doesn't explain why at rest your face is just tight. Okay. Okay, so back just to reinforce our previous algorithm, Bell's palsy patient, physiologically viable muscles, yes. Dynamic range, I would say this is average, right? He's got something that moves. What am I going to do? Am I going to signal upgrade? No. Am I going to put a new muscle? Maybe. But can I optimize things so that things will move better? Based on this previous images, we have elevators fighting depressors. Maybe if we rebalance the muscles, optimizing them, we may get some more movement, better movement. So that would be what I would do in this situation. So this patient had Botox, and eventually I told him, I think you may need a gracilis. But let's balance that muscle first and see if it doesn't work the way we want, then you can go and get gracilis. So I did selective myectomies, right? And at the same time, she insisted I should put a cross-facial nerve graft in case we need a gracilis. So I did a cross-facial nerve graft and selective myectomy with terminal neurolysis. So I think the confusion is in myolysis, neurolysis, or myectomy. I did both. Terminal neurolysis. That's a new term, right? So I cut them. Great result. She didn't want the gracilis anymore. So we got lucky there, right? So that's the same way we think about that problem. This is a patient with a lidocaine test. I think the lidocaine test works very, very well because of the sodium channel issues that we are talking about. And it sort of diffuses into a broader area. So I use it to sort of reassure myself, reassure the patient that, we could do something. This patient had Botox twice. Lidocaine test at the first visit because she was crying, and I wanted to show her that we can make a difference. And then she had Botox twice, and then went on to have a selective myectomy. We already saw this, that the facial artery helps us a lot. This is to show, this is the patient I did under local. Right away, she started having improved movement. So it's a very effective procedure. Platysma goes all the way to the eye. You cut it in the neck. It can have influence on the eye. Okay, and then selective myectomy around the eye can really make a big difference, but you have to do it carefully. So this is that patient. So she has improved, but you can see her lip, lower lip still covers the teeth, right? I can get more movement here. It's not going to make a big difference. Her issue is here. So I Botox the other side, and then she's happy. So we didn't do a gracilis. This is the other patient that we talked about. And then this is on the table using a 3mm biopsy punch. Right away, you see we're beginning to see more lateral gutter, and then this is an improved smile, and no open neurolysis, like more extensive. Okay, so we're talking about If the muscle potential is good, signal upgrade. If it's average and it's a synkinetic, you can just optimize the muscle. If it's irreversible, you do a muscle upgrade. So that's a summary slide. So you've decided that somebody's muscle is reversible. So you want to signal upgrade. Which donor nerve do you choose? Okay. We have the fifth to the seventh nerve. This will be a masseter to seventh. We have 7 to 7. That will be the proximal stump in the mastoid is available. If it's always available, go after it. Get a neurologist involved, go after it. There's nothing better than the proximal ipsilateral nucleus moving the face. So fitting to get that ipsilateral nerve, even if it's in the bone. Alternatively, is the contralateral side, and then there's the hypoglossal. Each of these nerves have their own attributes. 7, I use 7 for tone, right? If someone is a school teacher, public speaker, and I think they need a masseter, I know the masseter gives me good excursion. It doesn't universally give me good tone. This is a paper by Nina here, showing us that we can actually predict what the masseter will do. Masseter is very good in bridging the asymmetry up to about 60%. So if I have someone who the difference is more than 60.6, and I said, now, the masseter may not be able to bridge that gap. I need something else, right? Especially if this person tells me, I'm a lawyer, I'm speaking all the time, I want my lips to be in the middle, or I'm a teacher, I want something that will keep the lips in the middle and give them tone. I start looking at hypoglossal. So I may do a masseter plus hypoglossal. Okay, so I use the hypoglossal a lot for tone. Okay, 7, we think we want it for spontaneous smile. We don't always get it. That's a cross-facial. Cross-facial, I don't trust cross-facial. It's just so finicky. Sometimes it works, sometimes it doesn't. So I won't put all my eggs in that basket. But that's what it's supposed to give us. So but we want to give patients that chance, right? And fit nerve, quick recovery, close to the facial nerve, good excursion. I like it. Okay. Whenever the facial nerve is interrupted in the IAC, and I can pull the entire facial nerve to the hypoglossal, I do that because I want to save myself an interposition graft. So this is a patient who had a hypoglossal, a 7 to hypoglossal transfer, 7 decompressed in the mastoid, good tone at rest. Hypoglossal is just great in giving you tone. But to get patients to use it to smile, not everybody can do it very well. Okay, hypoglossal is very good in bridging the asymmetry gap. So if the facial asymmetry index, we're starting off and this one is 51, this is 68, masseter is not going to do it for me. It's just not going to bridge that gap. I will use hypoglossal to bridge the gap. I may add masseter to it to give me excursion. This patient had an acoustic. Pre-op, the asymmetry is less than 6 millimeters. So I know masseter only is good for me. So masseter only, good symmetry at rest, good excursion. So we could predict what a masseter only would do. But the previous patient, I could tell if I do a masseter only, it's not going to work. So I could choose to do a masseter and a fascial lateral sling, right? The sling will give me the tone and the masseter will give me the excursion, but it's a dynamic system. I like dynamic stuff. So I want the nerve instead of the static sling, because the sling, I may have to do it again, right? So usually in those cases, I will use the nerve. So again, this is what we use to try to kind of determine what you need. Okay, so knowing the attributes of these nerves, you can combine them. You can combine them to get what you want. The combination of 12 and 7, 12 and 5, 5 and 5, 7, 7. So just know that they do different things. This is a patient. Asymmetry is about 7. Masseter alone may do it. She's young, good excursion, but at rest, it drops down. Okay. She later on asked me to do something for the right side. And I did. This patient, right away, I knew that her facial nerve was cut. She's young, and I wanted spontaneous movement. I used masseter because it would get me quick recovery, but I did a single stage cross facial. Same setting, cross facial from the left side, plugged in on the right side, plus a masseter at the same time. I know the masseter is going to get into the muscle whilst the cross-facial is coming. So you can do cross-facial as a single stage and it works. But you have to have something that keeps the muscle alive. And if you do it early, you have time. A cross-facial growing, like she had a surgery, I did the animation within a month, right? By the time the cross-facial comes over 6 months to 9 months, I will get something out of it. But I also had a masseter cooking on the right side. Just to show you, this patient had a radical parotidiectomy and post-op radiation. I went after the facial on the ipsilateral side. I did a masseter to combine. Her smile is symmetric, dental display, and this is even after radiation. Okay, so whenever you have the chance, you want to do a combination. Now, this is a special situation. Whenever your nerve has to cross the radiation bed, it's going to be slow. So I usually like to put in a masseter quickly because the masseter will be out of the, how am I doing for time? I'm getting close. Okay, I'm going to speed through. Yeah. So when I know the patient is going to have radiation, I usually definitely want the masseter nerve because by the time the 6 weeks they get into radiation, the masseter has almost gone out of the radiation field. So I usually like a masseter and I hook it up very anteriorly, as anterior as possible, so I can get it out of the radiation field. Because when I know they're going to have radiation, that's what I'll do. Another thing is, when I know a patient is going to get radiation, I vascularize the surgical bed. Usually my nerve graft is the ALT, the motor nerve to the vastus. You're harvesting the vastus and the muscle, a lot of blood vessels. When they are done, their skin looks really good and it helps sort of protect the patient. So this patient had a radical parotidiectomy, and this is a vascularized nerve graft with fat on the face. The primary thing is not just what the nerve is doing, but how a radiated skin looks after you've put a vascularized tissue in that bed. Okay. I'm going to go through the next few slides really quickly. There's one clinical situation that I find very difficult. When you have a patient who has a facial schwannoma, we know it's benign, right? Their face looks okay. What do? Do you wait for the face to be completely paralyzed or House Brackman 3 or 4 before you intervene? Because that's the current recommendation. And my thought is that you don't do that. So I will go through this quickly. For schwannoma patients, I will preemptively innervate them. As soon as I see that they have a dynamic process, it's not static, the nerve is getting weak, even if it's a House Brackman 2, I will innervate that nerve, muscle. I'm not waiting for it to become a 3 or a 4 before I do something. The reason, what I see is that when you innervate, it reverses the paralysis, it protects the muscles, and then you can decide what you're going to do with the nerve. Let me go through this really quickly. I will show you a particular case. Okay, this patient had a schwannoma, and I knew they were going to cut the tumor out and cut the nerve. So I preemptively innervated, and once we saw masseter nerve function, that the masseter nerve was moving his face, then they went in and took the tumor out. Now, this is the patient post-op, like in the pre-op, in the post-op area. His facial nerve has been cut, completely cut. Now we're going to ask him to clench his teeth. Let's see. Too long. It's a strange thing to have someone's nerve totally cut and they're still smiling, right? And it's everything from the masseter that was pre-innervating the area before the surgery was done. So this was almost like 3 months after a masseter nerve. And then once the tumor was removed, his face improved to what I previously showed. Let me see. This is all messed up. But so I do preemptive innervation for patients with primary facial nerve tumors. I don't want to wait for the nerves to go really bad before we do something about it. Let's just go through this quickly. This is another patient, a teacher, very early weakness, preemptively innervated. And then we have an improvement. And now we can watch. I feel comfortable watching the tumor because now he's got an alternative nerve supplying the facial muscle so it won't continue to deteriorate. Okay, you can see that we have improved lip escutcheon over what she had preoperatively. And now we can decide on what we do with the facial schwannoma. I have over 12 years of experience with this, and the result seems to be very consistent. Okay, so I will end with the situation where the muscles are irreversible. Okay, Mobius being one, we're going to go through them quickly. This is a Mobius patient I did in Germany. Her result, Mona Lisa smile. So Mona Lisa smile is the baseline result we shoot for, but it's not the same as the picture that I showed you earlier on with that little kid with a big smile, right? So we want something better than that. So this is how I started doing gracilis. I always had a single muscle, a belly, cross facial, and masseter nerve, almost never a single graft, single nerve, always dual innervation. The muscles are small. So tendon on one side, I tend to take it on the contralateral side, right-sided paralysis, left-sided gracilis, if I'm going to use the facial arteries to innervate it. So we get the size right, we get the tension right. If we don't get the vector right, we will get a Mona Lisa smile. But we want more than that, right? So this is another patient, a young patient who had a brain stem tumor, left-sided paralysis, univector gracilis, and the result to me was good, but not the same as that kid, right? So we need to do something better. So again, we can get these smiles, but we want that smile, okay? To do that, we have to replace a lot of the elevators of the lip as much as we can, or at least try to follow the vectors of movement of all those muscles. This patient had paralysis. This is a gracilis. To me, that's a very nice smile. But when he tries to do an open smile, you can see that there's labial drape and the medial lip is not elevated. So that's the thing that really pushed me to work on the multi-vector gracilis. So the anatomy of the gracilis allows us to carefully tease out the muscles into two muscle bellies. 3 muscle bellies, have one under the eyelid, one be zygomaticus minor, zygomaticus major. You can even add a 4th one to be the lower lip. It's just because of the way the muscles are innervated and vascularized in this direction. So you can carefully tease them out. And usually, commonly, it's a smaller muscle, 1.5 centimeters by 7 centimeters, inserted on the malar bone. The other one will be that 2.5 by 9, inserted to the root of the zygomatic arch, and then innervated by a dual nerve. So here is an example. This is a neurovascularized segment, and when you stimulate, you can see independent movement of both, okay? And this is an example of a 3-segment with one going under the eyelid. I'm going to go through this quickly. And this is an example of the result that you can get. So now I can get lip movement, a full nasolabial fold, and just a really broad smile on somebody who had a right-sided paralysis. And with that, I can get a really full smile with the upper lip elevation with a double innervated and 2 vector gracilis. This is the same patient, 4 months. First, you can see only the first paddle starts moving first, and then afterwards, the second paddle, 4.5 months later, 6 months later. So you can usually see the progression. The first paddle starts moving, then the second paddle follows up. This elderly patient, multi-vector gracilis, very broad smile. That's the way I can consistently get the smile that I want. Now, can you use a univector flap to do this? Yes. If the patient's facial habitus allows you to put the muscle more medially without creating bulk in the cheek, you can do that. But if it doesn't, then you have to use a smaller muscle to get that medial lip. This is another patient from Iran. First paddle, second muscle moves the upper lip. Another patient. This patient had a traditional temporalis muscle that you take the belly over the zygomatic arch to pull the corner of the mouth. I reversed it. And then, so there's a lot of scarring, and still we get a decent result. Another patient. And you can get a decent result. Yeah, another patient, I'm going to go through it. Okay, so summarize. Complex system. You have to have something that allows you to decide what you're going to do. For me, take the muscle, think about the muscle as being reversible. Ask the second question, the dynamic potential. If it's average, you can go either way. If it's poor, you need a new muscle. If it's good, innovate and do it quickly. And if you want a good smile, you're looking at dynamic movements. We are not where we want to be. We need to push the envelope. Thank you. If you have questions, yeah.
Thank you so much, Kofi. Any questions from the Zoom audience or? Has any questions, feel free to use the reaction icon to this is the world we live in now. Or Zoom. Put some questions into the chat and I can ask them. That was a wonderful summer. I mean, we could probably sit here for hours watching, all your amazing results, and it's really cool to see how your thoughts have evolved and your surgical skills amazing. So thank you so much for sharing with us. It's late. I know everybody wants to be moving. We have to go to dinner. I want to thank you. This is just a little something from us here at Stanford for you. So I hope you can enjoy it.
My favorite color. Thank you very much. Thank you.
You're welcome.
Yeah, that's awesome.